Hello, class. Dr. Mike Burford here. I want to talk with you a little bit today about our psychopathology class. Today we're going to cover anxiety disorders and obsessive compulsive disorder. And again, I want to remind you that the disorders that I cover are the ones that I frequently see or have seen in the psychotherapy clinic. And I also have two of the books, two of the books that I've either required or requested that you use in our class. This, of course, is the DSM-5 that I've asked you to get, and of course it'll be useful in helping you make diagnoses and all that. And again, this is the book that you'll use when you're in practice, most likely, to help you with diagnostics. And then the other book is a recommended book. It's not required, but this is the Barlow book that's in your syllabus. And the Barlow book is really good in that it provides information not only about diagnosing, but it also provides great information about treatment protocols and treatment approaches. And I really value this book. It's a great scientific book, and I hope that you get this book and use it as a reference in your career. I know I certainly use it in mine. One of my mentors had that book laying on his desk one day, and I asked to look at it and liked it, and sure enough decided that I needed to get that, and I've used it many times since then. Okay. So again, today I want to talk about anxiety disorders and obsessive compulsive disorder. And I want to remind you that the information from these slides are, most of the information is taken from the DSM, with of course the exception of treatment information. Now, let's talk a minute about anxiety. I commonly see people with anxiety in the clinical office. Just today, as a matter of fact, earlier today, I had a couple of people in that suffer from anxiety, and anxiety is their primary diagnosis. By the way, I'll say something to you that's a bit unscripted that I hadn't thought about until now in terms of sharing with you. But if you have a person that comes in and they present with maybe 2 or 3 disorders, maybe they have 2 or 3 problems, and they say, well, the main thing that I'm interested in is working with anxiety or depression or what have you. Now, in the long run, it could be that you end up treating all 3 of the problems that they present. But oftentimes it may be that somebody comes in and says, well, okay, I have, for instance, I have an anxiety problem, and they have anxiety disorder. And that would be the thing that bothers them most. That would be the thing that they identify that they want to address. And so even though they may also have some other problems, you would focus on the anxiety problems and get that squared away. And then later on, once that's done, perhaps give them the option of addressing the other issues. When someone comes into your office and they're talking about having problems with anxiety, they may use phrases like, I had a nervous breakdown. I've heard that a bunch of times. I heard that growing up, actually. They may tell you that they have quote unquote bad nerves, that their nerves are acting up. I've had some of them come in and say that they're going through spells, and I'll think to myself, well, okay, now what do they mean by spells? What do they mean by nervous breakdown? What do they mean when they say their nerves are acting up? And even when somebody comes in and says that they have anxiety, what I want to know is, what is it exactly they mean by anxiety? Their definition of anxiety and mine may be 2 different things. And the same thing with all these common vernaculars they use, nervous breakdown, problems with nerves, having spells and all that. I'll say, well, what does a spell mean? Tell me about your spell. What does that look and feel like? And the same thing with the nerves and the nervous breakdown. Generally, though, what they're talking about, of course, is having anxiety and experiencing overwhelming anxiety. And of course, I never belittle them for using phrases like "my nerves are bad" or having a spell or a nervous breakdown. And one of the other things that I wanted to bring to your attention, what I've noticed over the years in working with clients, is that it is indeed helpful to take a here and now approach. And what I've learned is that people that come in and that say they have anxiety or they report anxiety symptoms, is that they tend to be future oriented. They tend to be concerned and worried about what might happen. And oftentimes, in their mind, what might happen is a bit far-fetched. They're catastrophizing, taking an event and imagining it at its worst. And then, of course, it causes them to have distress and feelings of anxiety. And then depression, of course, would be the opposite. People that come in to see me who report depression, significant depression, tend to be the type of people that focus on the past. They live in the past. A lot of times they don't have a whole lot going on in the here and now. And that's not always true, but oftentimes people come in with depression and they're living in past relationships or past experiences, past abilities, those kind of things, as opposed to living in the here and now and engaging things in the here and now. And so I think that mental health can be found in the present, in the here and now. Now, does that mean that we don't take into account things that have happened in the past and learn from them? Well, of course not. We learn from the past. At least hopefully we do. And it also means that we would be amiss not to plan for the future to some degree. But as a general rule, I teach people to live in the here and now. And that's where the most mental health is found, in my opinion. Okay, well, let's talk a little about generalized anxiety disorder. Generalized anxiety disorder is one of the two most common disorders that I see in my client base, that and depression, major depressive disorder. So what do we know about generalized anxiety? Well, we know that, I should say generalized anxiety disorder. Well, we know that it's a disorder. It causes a disruption in one's ability to function appropriately. We identify it as having excessive anxiety and worry about various things, not one thing in particular, but a variety of things. And so when I ask one of my clients about their anxiety and to describe it, oftentimes they'll say things like that they have anxiety continuously, that they're always worried every day, most of the day, and they're worried about a variety of things. And I've even had some tell me, once we were getting into their therapy, that if there is nothing to worry about, they'll create something to worry about. They will ruminate about something until it becomes an issue, a problem. And they'll do that with several different things, and so that they have a whole plate full of things that they're worried about and anxious about. Anxiety may include restlessness and fatigue, poor concentration. People with generalized anxiety may be irritable. Oftentimes there's a sleep disturbance. And a lot of times they'll tell me that they feel like that their body is a spring coil under pressure. So they have muscle tension. Sometimes they tell me they feel like that they're about to explode, that they have just a ton of energy and that they need to get up and move around. These people also tend to have difficulty controlling worry. You've heard the term worrywart and all of that. Well, chances are a person that may be termed a worrywart is a person that suffers from generalized anxiety. And again, it's present most every day, usually all day, and it's present for at least 6 months. A person that has generalized anxiety disorder has been generally anxious for at least 6 months. So what I found in working with people with generalized anxiety disorder is that oftentimes they've been anxious since childhood. They can identify first thoughts and feelings of anxiety when they were a child, and it's persisted throughout their life. And with those type of people, it may be reasonable that they have an anxious temperament, and that indeed they'll probably have some anxiety for the remainder of their life. My goal in such cases is to reduce suffering as much as possible and to help give them tools so that they can reduce and manage their anxiety that doesn't seem to go away and it's treatment resistant. So again, what I do is provide a little psychoeducation with people with generalized anxiety and say, well, hopefully we can get rid of all this anxiety, but if not, we'll at least reduce it and make it manageable and give you some tools to help you live a better life. Now, of course, like I said before, with generalized anxiety disorder, it is a disorder that disrupts functioning ability. Now, sometimes I give the diagnosis of unspecified anxiety disorder. And for people that have unspecified anxiety disorder, they have anxiety symptoms and they have functional impairment, but they do not meet full criteria for other anxiety disorders, more specifically generalized anxiety disorder. Or it may be that I don't have enough information to say that this person has generalized anxiety disorder, and it may be that I need to give a provisional diagnosis, or could be for whatever reason, maybe I don't ever get the full story, which would be rare, but I guess that could happen. But anyways, unspecified anxiety disorder is sometimes useful if we don't have enough information yet about the client, or if they don't meet full criteria. For instance, maybe they have all the criteria for generalized anxiety except for the 6 months time period that's required. Maybe they've had it for 4 months or 3 months or 5 months or something to that effect. Now let's talk about panic disorder for a minute. I wonder how many of you that are in class that are watching this video have experienced panic attacks. And if you have, you probably know it. Physical symptoms can be very severe. I've heard it described as a feeling of the walls are closing in, a feeling that their heart will beat out of their chest. I've heard people tell me during a panic attack they can actually hear their blood pumping in their body. They sweat sometimes. Sometimes they get abdominal cramps and stomach cramps, that kind of thing. Sometimes they shake and they get dizzy oftentimes. And oftentimes it can escalate, a panic attack can escalate into the person feeling like they're having a heart attack, and they oftentimes end up in the emergency room complaining of heart symptoms and thinking they're having a heart attack, and it turns out that their heart checks out to be just fine, and it's a panic attack. So panic attacks can be very severe, and sometimes they're not so severe, but a lot of times they are. They can range in duration. Sometimes they're just a couple of minutes, and then I've had clients tell me that it lasts for them up to 30 minutes, and perhaps even more. And then for the panic disorder, what has to happen is that, of course, a person has panic attacks, and then they become persistently worried about experiencing more panic attacks, because panic attacks can occur spontaneously, and there seems to be no rhyme or reason. For instance, you could be at the grocery store, a panic attack may hit. You could be standing in your living room and a panic attack may hit. You could be outside in the garden and a panic attack hit, or driving a car. Sometimes they hit with no rhyme or reason. On the other hand, occasionally I've had a client tell me that they would panic attacks would occur when they're doing certain behaviors. For instance, I remember a client that I had that told me that when she was driving a car, they were more likely to occur, especially when she got to a certain part of town where maybe the road was a little more narrow, or maybe the traffic was a little more heavy. So what happens is that a person that has repeated and recurrent panic attacks sometimes begin to get worried about when they're going to have that, and then that worry impacts their life. Now, for instance, it may be that a person with panic attack and persistent worry and fear of having a panic attack decides that, well, I'm not going to leave home because of it, because it's humiliating for me to have a panic attack out in public. Or it may be that they avoid the grocery store. I had one client several years ago who would have panic attacks in the grocery store, and it got to where she just simply refused to go to the grocery store. Somebody else would go to the grocery store in her family. And in fact, just talking about a grocery store in my office would cause her to experience discomfort. So that's panic disorder. All right, so now I want to talk a little about specific phobia. Now, how is specific phobia different from generalized anxiety disorder? Well, okay. Generalized anxiety, as you have just heard, is general. People worry about a variety of things. So with specific phobia, there is a specific thing that a person is in fear of or has anxiety about. It could be a certain object or a certain situation, and that fear is excessive and inappropriate. So for instance, if I have a fear of spiders, for instance, we wouldn't necessarily consider that a disorder, unless I let it disrupt my life and I refuse to leave my bedroom, for instance, because I was afraid that I would encounter a spider. Then we could say that I have a specific phobia of that. But in general, if I'm functioning pretty well, but yet I have a fear of spiders, then we certainly couldn't say that that was a specific phobia that was in need of clinical attention. All right, so for specific phobias, we need an excessive, inappropriate fear or anxiety about a specific object or situation. And the phobic object or situation produces immediate fear or anxiety. It's an immediate irritant. And the person tries to avoid situations or avoid those objects that would cause the fear or the anxiety. So they go out of their way to avoid such things. Now, generally, specific phobia lasts for 6 months or more. So if it lasts less than that, according to the DSM, we wouldn't necessarily diagnose specific phobia. But if it lasts 6 months or more, then we can say that, yes, this person has specific phobia. Now, I want to say something else, too. The DSM is a guideline. Your clinical opinion can, at least to some degree, overrule hard, fast guidelines in the DSM. Now, for instance, I've been a psychotherapist for around 15 years or so. I was counting that up just, I guess, last night. But I've been around long enough to where I know some of the diagnoses very well, and I know the flavor of those. And on occasion, I'll get somebody in that mostly meets the criteria for something, but there may be something that doesn't quite fit. But I'm still able to say, well, yeah, this person has that flavor of that disorder, and I believe that that's what that person has. based on practice wisdom and then some of the other things that are found in the DSM and maybe some current research and all that. So on occasion, it's appropriate to use your clinical wisdom and maybe overrule some things in the DSM if necessary. But you have to be really careful doing that. That's not something you want to do lightly if you want to make an accurate diagnosis. Now, again, specific phobia, there has to be an impairment in functioning. Again, that's the definition of a true disorder, right? And I want to share a case with you that I had years ago, and I'm going to change things a little bit so as to protect confidentiality. So I want to tell you about the case of Tommy, and of course Tommy's not the person's real name, but I remember when I met Tommy, he and his parent presented to me, and Tommy was a little boy who was afraid of candy bars, oddly enough. And what had happened is that Tommy had gotten a chocolate candy bar and had tried to eat it one summer's day in the car, and the chocolate had melted, and Tommy ended up with chocolate all over his face and his hands and his arms and his shirt, and everything he touched, of course, had chocolate on it. And so there was a big chocolate catastrophe, for lack of a better description. Tommy developed a phobia of chocolate because in his mind it was a nasty, messy, insidious substance that that he would have to deal with to the nth degree if he were around it. And it got to the point with Tommy that he not only refused to eat chocolate, but he avoided it completely. If he was in the store, he would have to make a wide swath, a wide circle around the chocolate candy aisle. Wouldn't even walk past it, but would have to move around it in a circular fashion and try to stay as far away from it as he could get. Tommy's phobia got so bad that he forbade anyone in his family to use the word chocolate. And if somebody said chocolate, he would cover his ears like this and act as if he had heard some terrible and horrendous thing, and he would make a big production out of it, and would demand that the person that said the word chocolate would demand that they promise to never say that word again. He would banish the word chocolate. And would admonish me in therapy when I used the word chocolate. So that was Tommy. He had a specific phobia. He wasn't afraid of any other type of candy, but it was chocolate candy bars that he would be afraid of. Tommy had some other problems too. I was going to tell you a little about Tommy's outcomes, but he had some other problems that had to be addressed, and one of which was pervasive and severe. And so Tommy is able to be around chocolate now, or it was when I last saw him, was able to say chocolate, still didn't eat chocolate, which is fine, but at least he was able to go in the store where there was chocolate and walk down the aisle where there was candy bars and all that, and didn't make a big issue if somebody else used the word chocolate. Imagine how disruptive that would be in the work environment or the school environment. You as students, when you're sitting in your class, well, imagine what would happen if you stood up and announced that nobody in the class needed to use the word chocolate or the word pen or pencil or whatever have you. That wouldn't go over too well, would it? And chances are your success might be hampered, and certainly true in the workplace. Okay, so now I want to talk about obsessive compulsive disorder a little bit. And by the way, there are other disorders in the OCD section and in the anxiety section of the DSM, but again, I'm covering the ones that I see frequently. For instance, I'll mention just briefly trichotillomania, whereas a person habitually pulls out hair, whether from their head or their eyebrows. And over the years, I've seen, I'm thinking of 3 people that I've seen that have done that. 2 were adolescents, 1 was an adult. And it's pretty uncommon to see that kind of behavior. And trichotillomania is usually secondary to some other, at least in my experience, some other disorder. And it can be interesting and all that, especially when you first see it. Somebody may have a patch of hair that's, out. I remember, for instance, one client that I had, a female client, and she had long, dark hair. She had beautiful hair, but there was a patch that was missing, and she would kind of cover it up the way she would comb her hair, style her hair, but she could move her hair back, and you could see this big patch of hair that was missing where she had pulled pieces of hair, pulled hairs out over time. And I remember another little boy that I had, and he would pull his eyebrows out, and half the time he would not even realize apparently that he was doing it, but he would come in and part of his eyebrow would be gone, or sometimes the complete eyebrow would be gone. It's very fascinating stuff. Anyways, but with obsessive compulsive disorder, OCD, you guys have probably heard quite a bit about it. But with OCD, we have obsessions that are recurrent, persistent thoughts, and urges or images that are intrusive and cause anxiety and distress. Attempts are made to ignore or suppress such thoughts, urges, and images. And then there are compulsions, which are rigid and repetitive behaviors or cognitions, and they're aimed at preventing or reducing anxiety. So these behaviors are aimed at reducing or perhaps preventing anxiety with people that suffer from OCD. The DSM guidelines require that the obsessions and compulsions take more than 1 hour a day or cause impairment in social, occupational, or other areas of functioning. So for more than 1 hour a day, a person needs to have obsessions and compulsions to garner a diagnosis of obsessive compulsive disorder. Now, the interesting thing for me to tell you about is that I have, on my caseload right now, I have 3 people that have obsessive compulsive disorder. And what I can tell you about people with OCD is that at least the ones that I've seen have been in treatment for a while, have usually had providers previous to me. OCD is, in my opinion and from my experience, difficult to deal with. And I'll talk more about all that shortly when I get into the treatment aspects of OCD. One of the things that you want to be careful about when you're diagnosing OCD is the differential diagnosis, and you, in particular, want to rule out substance abuse because, like most other disorders, they can mimic signs and symptoms of substance abuse. And by the way, there's an interesting little phrase, signs and symptoms. Can somebody tell me the difference between signs and symptoms of a mental disorder? Well, signs are what other people see. Now, for instance, if I'm sitting with you and I see that you're fidgety and that you can't sit still at all, and that you have trouble focusing and that kind of thing, then I may say, well, this person has signs of ADHD combined type, for instance. Whereas if you're telling me your symptoms, if you're telling me the things that are bothering you in relation to whatever particular disorder, for instance, You may say, well, gee, Mike, I have trouble sitting still. I always have to be fidgeting with something. I get in trouble a lot because I can't be still. I'm into everything coming and going. It's like I'm driven by a motor. I can't concentrate very well. I'm always on tangents about things. Just really have trouble with focus and all of that. Then as a person that has those things, then you would be talking about your symptoms as opposed to signs of your disorder. So the difference between signs and symptoms, there is a difference, and you'll probably hear signs and symptoms used a lot when you become clinicians. Okay, I want to talk just real briefly about whether OC traits, I guess I should say, are pathological. Now, for instance, I have known people who, before they go to bed at night, would check the door a couple of times to make sure it's locked. Well, for instance, they may go and lock the door, and then maybe 30 minutes later they go into the kitchen. They're going to grab some popcorn and maybe a soda or something, and they say, oh, while I'm here, let me just glance over and make sure the door is locked. Or perhaps they check the stove a couple of times before they go to bed or before they leave. Is that obsessive compulsive disorder? Well, not necessarily. Again, we think about the definition of a disorder, right? And I know you guys are probably getting tired of me talking about that, but it's important that you know the difference between traits and a disorder. The disorder, of course, is something that disrupts one's ability to function. Now, if I am checking the door so frequently that I can't perform my other duties in the home, then yeah, that's a problem. Or if I've gotten in the car and I'm a mile down the road and I have to turn around and go back to make sure I check the door, yeah, that's a problem. Especially if it causes me to be late for work or late for a meeting or with a friend or a dinner or what have you. So what I'm saying is that it's quite possible to have traits of obsessive compulsive disorder but not actually have the disorder. For instance, the person that needs to check the kitchen door a couple of times, maybe they look at it while they're getting their popcorn, or maybe they're getting it while they're getting a drink of water. They look at it. Is that pathological? Not necessarily. It's not disrupting their life. I can use myself as an example. Sometimes I'll be out digging in the garden, or my wife and I have a pretty extensive flower garden, and we've got some vegetables too, and sometimes I'll be out there putzing around trying to relax a little bit, and I'll come in and wash my hands, and then, 10 or 15 minutes later, I'll decide to make a sandwich or something, and then want to make sure that I wash my hands again to make sure all the dirt's off my hands, or, maybe I've been out there petting the dog and, it slobbers on me or whatever, and I'll come in maybe and wash my hands, and then maybe shortly thereafter wash them again. Is that obsessive compulsive disorder? No, it doesn't disrupt my life at all. And I do like to be clean, as hopefully you do as well. Anyways, now let's talk just real briefly here about treatment. Again, you'll have more about treatment protocols and all of that when you have some of your other classes. But I do briefly want to talk about treatment. All right, so for treatment for anxiety disorders, commonly cognitive behavioral therapy is used. And in that, basically what you do is identify and challenge erroneous thoughts and beliefs. You help people reframe and look at things a little differently, and replace thoughts and beliefs that are harmful or incorrect. CBT can be a very powerful tool. Just last week, I had a client that came to me that has been suffering with guilt probably for 3 decades now. Longer than that, now that I'm thinking about it. But anyways, for many, many, many years, for a long time. And that guilt was based on thinking and a belief that she had that was incorrect. And so for years she had this secret and this guilt that she carried, and it was very heavy for her. And it was all based on incorrect information. And so we were able to identify that and to gently challenge that belief. And I was able to provide her with information, accurate information that was used to displace the incorrect information that she had. So isn't that something, though, that somebody would suffer for all those years based on erroneous thoughts and beliefs? And that's not uncommon, actually. And so CBT can be very effective with helping that. Also, I like to use existential psychotherapy when appropriate, to be existentially minded and look at things in terms of the big picture and various other things. So that would take us off track of what we need to be doing today. So if anybody's interested in hearing more about existential psychotherapy, I could talk with you forever about it, and would be happy to make an appointment and have you to sit down with me, and we can have some interesting discussion about that. Also, psychoeducation goes a long way, especially with like panic attacks. I'm thinking of a client that I have now that had some serious panic attacks, and I was able to provide psychoeducation to her and to help her do some self-talk along the lines of, well, hey, I know what this is. This is a panic attack. It's not a heart attack. It's not, the world ending. It's not that the walls are closing in. None of that's true. What I have is a panic attack, and I know things about panic attack. Dr. Burford has taught me about panic attacks. I know that this is time limited. I know that I'm going to be okay once this passes, and in fact, I'm really okay now. I don't feel okay, but I'm going to get through this just fine. This is a time limited thing, and all I have to do is hang on for a little bit, and this will pass. And then I teach them to know and recognize that's what it is, that it's not some big monster. And then eventually clients begin to think, well, okay, this is just another one of those silly panic attacks, not a big deal. I'm going to chill out for a minute and wait for it to pass. And then what happens over time is that the panic attacks become less severe and less frequent, because the person begins to realize that, well, really this is not anything to be worried about. It's just a nuisance more than anything. And then the symptoms and all that tend to subside with time, especially if psychotherapy is done to address other anxiety issues that are likely to be experienced. And so it all kind of works hand in hand. And by the way, seldom do I see somebody with panic attacks and panic disorder that doesn't also have generalized anxiety disorder. I'm not saying they have to happen together, but in my practice, it seems like that they co-occur very frequently. So between psychoeducation and cognitive behavioral therapy or existential psychotherapy, we can usually get anxiety disorder and panic attacks, panic disorder under control quite nicely, although it does take a little time. Also, psychoactive medications can be useful. Now, providers, the physicians, psychiatrists, family doctors, nurse practitioners, physician's assistants, those types of people that can prescribe meds, they are very wary of prescribing benzodiazepines for anxiety, things like Xanax, Valium, and Klonopin. I have seen cases where some of those, like Xanax, for instance, might be needed for a short term, but it's certainly not something that mental health people like for clients to be on for long periods, because obviously they're addictive, and kind of like a Band-Aid in order to help somebody muddle through until more permanent things can be done to help with change, things like psychotherapy. An example, I guess, for the appropriate use of Xanax would be if somebody has a loved one die, and they're just overwhelmed to the point that they're not functioning, and they're in a panic, basically, and not panic in terms of a panic attack, but just in a panic, and perhaps they need something for a couple of days to help them get through. Now, as a provider, I can tell you that I'm never amazed. I never cease being amazed by the ingenuity of people that come in that are trying to get benzodiazepines prescribed to them. I've often had people try to get me to prescribe them. I'm not a physician. I can't prescribe medication. I've had people get mad and walk out when they realized that I wasn't going to be able to prescribe medication for them. I have had people say to me, yeah, I know that you can't do it, but I know that you're probably buddies with a person down the hall that can. And by the way, can you refer me to that person, and can you tell them that I need this medicine? Sometimes I do refer them, but I certainly don't tell a physician that I think that somebody needs medicine. That's their job to figure that out. But I can tell you that they're very wary of prescribing those, and they should be. We have lots of people that are drug seekers that come in, and again, they can be very clever. I'll tell you a real brief story. I remember many years ago, I was working on a psychiatric unit, and part of my job, I was working night shift, and part of my job was to go down to the ER and do evaluations on people that came in with mental crisis. And oftentimes there would be drug seekers. And I remember one person that came in, and she was a woman, middle-aged woman, and she told us that she had been beaten and raped, and that yes, she was a person that frequented the streets and had a rough lifestyle. She was forthcoming with that, but said that she had been beaten up and had been raped. And granted, you could look at her and tell that somebody had beat on her. And her eye was all puffed up, and her lip was, had been bleeding, and her hair was a mess, and various scrapes and contusions on her arms and that kind of thing. And so I felt really badly for her, and wanted to do the very best I could to help her. And so I went to the physician, the ER physician, and I said, well, look, this gal's the real deal. I think that we can pretty much trust what she has to say. And so he ended up prescribing her, I don't remember what it was, some kind of benzo that he prescribed. Well, we found out later that this gal made a point of going to the different ERs and had a very believable story and all of that. And so I got duped. She tricked me. And I don't feel really badly about that, because it will happen sooner or later to you. Because if you think about it, we're in a bit of a precarious spot. We want to help somebody, and we'd like to give people the benefit of the doubt. We're there to try to relieve suffering. But we also have to be wise that sometimes things aren't as they're presented, and that there's an ulterior motive, and the motive is not to get well and healthy. That's also true for people sometimes that come in that have been accused of a crime, and they have a court date coming up, and they're trying to, their lawyer sends them over to get therapy and says, well, we need to show the judge that you're getting therapy so you'll get a lighter sentence, or we need to show that you're in therapy and that you're a pretty good person, and that, yeah, you need custody of the kids versus the other spouse or the other parent, whatever the case. And so, and then a lot of times what will happen is that somebody will come in and they'll act like that they're there because they want therapy, and the reality is they're there because they intend to have their lawyer subpoena you to court, or maybe they want you to write a letter in support of their mental status to the court, those kind of things. So be wary. Not everybody that comes to you for therapy is there because they want to be. And indeed, some may be court mandated to be there. And I'll say something about that in just a second. But a lot of people there, not a lot, but some people there will come in because of ulterior motives. And so you need to be mindful of that. I tell people up front when I talk with them about confidentiality and having to report suicidal ideation, and if they're intending to hurt themselves, I have to report that, and I have to report homicidal ideation, and I have to report if abuse is occurring, whether they're a perpetrator or a victim, and all that. I give them information about all that up front. I also tell them a little about me so they'll know who they're working with, and I tell them what to expect in psychotherapy and how things tend to work, and I tell them about the importance of a therapeutic relationship and communication and all that. But one of the things that I tell them is that I may get subpoenaed to court, perhaps by your lawyer if you have one, if there's something going on, or perhaps by somebody else's, and it may be that I have to go and testify. I let them know that I don't like to do that. And that when I go, I do my very best to protect their confidentiality. In fact, I tell them that if they're looking for someone to go to court, they need to go to a different therapist, because I don't want to do that. And my intention is to be as protective of their information as possible in court. And having had to do that many times, I can tell you that going to court is generally a very unpleasant experience. You'll have lawyers that are clawing at you and trying to make you into somebody that's lying and or doesn't know what they're talking about, and that kind of thing. It's a nasty experience, or at least it can be. I guess some people enjoy it that are pretty good at it. I guess people that are into forensic psychology and all that. But I don't enjoy it, and most therapists that I know don't enjoy it either. So, however, if you think that you might, there are people that are forensic clinicians that would probably be happy to talk with you and help you go down that path of for a career. Anyways, there was something I was going to say to you about that I mentioned earlier, and I've forgotten what it is. I apologize for that. All right, moving on. Treatment for obsessive compulsive disorder. By the way, if somebody sees the tape and says, oh, that must be what it was he was going to tell us, send me an email and I'll be happy to address it in the next video. All right, obsessive compulsive disorder treatment. One of the things that I try to do is I try to teach coping skills, things like Jacobson's progressive relaxation technique, things like mindfulness meditation, things like breathing exercises. The reason that I teach those is because I want my clients to have some skills to help manage and perhaps de-escalate their anxiety when they do other things that I'm asking them to do regarding OCD. Such as being abstinent from certain behavior. Earlier we said that a certain behavior keeps anxiety at bay, and so if I'm asking a person not to engage in that behavior, then obviously their anxiety may go up, at which time they'll need some of those coping skills that I just mentioned. So the number one thing is to lay a foundation of coping skills so that they can use as necessary. In CBT, we talk about extinction. We're trying to cause behaviors to become extinct. We're asking that people space out times that they're doing certain behaviors. For instance, I had a client that needed to check his vehicle to make sure it was safe, and he would do that excessively. And so I got him to where he was doing that at intervals that were further and further apart, and eventually to be abstinent from that. Also, it's useful to repetitively talk about the issue. Nothing against horses, but you've heard the phrase, beat a dead horse. Well, there's at least been a few studies that show that that's useful in it causing behavior to become extinct, is to talk about it and talk about it and talk about it and talk about it. And also I give homework. I send people out and I say, well, okay, press the issue and let's see how far between you can get these episodes of behavior. And I want to tell you that even slight gain can be very useful for someone suffering from OCD. Just the slightest change can make a big difference, because these people tend to be suffering greatly. And it really can mess up their life, OCD, and their family. And so you want to involve loved ones. I'm thinking of two people right now that I'm treating in psychotherapy, that we have their loved ones involved in their recovery. And also, of course, psychoactive medications may be an option. And finally, want to remind you of the use of the DSM in this video. That's where I've pulled most of the information for this video. And the last slide you'll notice is a reference slide, which is appropriate form for doing PowerPoint presentations if you use somebody else's material. In fact, you could even put little footnotes at each slide. I chose not to do that because I'm telling you verbally that, and before and after the slides, in the slides, that I'm using the DSM. All right, so there is information on anxiety disorders and obsessive compulsive disorders. And study hard. I know you have a lot of work to do. Welcome to graduate school. Learn a lot, and I'll see you next video.